The following podcast is part of a certified educational activity titled Don't Fail Them Now, Bridging the Gaps in the Diagnosis and Treatment in Transthyretin Cardiac Amyloidosis. Access the entire activity and complete the post-test at peerview.com/QTM860. Downloadable slides and practice aids are also available.
Welcome to Don't Fail Them Now, Bridging Diagnostic and Treatment Gaps in Transthyretin Cardiac Amyloidosis. My name is Dr. Michelle Kittleson from the Smith Heart Institute at Cedars-Sinai, and joining me today is Dr. Senthil Selvaraj from Duke University School of Medicine. So our goals for today: learn how to recognize the signs and symptoms of ATTR cardiac amyloidosis, use the guidelines to distinguish ATTR cardiac amyloidosis from other cardiac diseases, and augment your understanding of clinical trials for emerging treatments for ATTR cardiac amyloidosis and their potential role in reducing hospitalization for heart failure and cardiovascular risk. So I'm going to start with Masterclass 1, Closing the Gaps in the Diagnosis of ATTR cardiac amyloidosis. We'll talk about the pathogenesis, natural history, and epidemiology. So let's dive in. What is cardiac amyloidosis? It's a condition where there's a protein the body produces naturally that, for reasons we don't fully understand, decides to deposit into places like the myocardium, resulting in a restrictive cardiomyopathy. There's hundreds of different proteins that may be implicated, but the two most common will be the immunoglobulin light chains, that is AL cardiac amyloidosis, and the transthyretin protein, TTR cardiac amyloidosis. And the ATTR cardiac amyloidosis in turn can have one of two sources. The protein may result from a mutation in the gene, that's the variant form, or it may be wild type. Now, in the olden days, we used to call that senile cardiac amyloidosis, but we do not anymore because that hurts people's feelings. So the proper distinction is wild type versus variant. Now, this protein just doesn't infiltrate the myocardium. It goes other places as well, and these other places can form the clues to diagnosis. There can be a neuropathy. There can be a nephropathy that's predominantly unique to AL amyloidosis, gastrointestinal involvement, and orthopedic or musculoskeletal issues. It's important to understand the pathogenesis of the transthyretin protein because that will offer insights into therapeutic targets. So the protein is produced in the liver and then forms a stable, happy tetramer to do its job. But in the case of amyloidosis, this tetramer dissociates, ultimately turning into an amyloid fibril, which then deposits into tissues. So this is foreshadowing for the future therapeutic targets, which would include the production of the protein, the stabilization of the happy tetramer, and then potentially removal of deposits from tissues. Now, when we think about the variant versus wild type, we know that there's over 130 pathogenic variants, and these can have varying phenotypes. So what do I mean by varying phenotypes? Well, it's important to remember that in addition to cardiomyopathy, there may be a polyneuropathy, and that there is a pre-symptomatic stage where the amyloid fibrils may be accumulating in tissues, but patients are potentially unaware. But then, as the burden increases, symptoms manifest. Why is this important? Again, foreshadowing to Dr. Selvaraj, who will tell you about therapies, that the current therapies should be started as early as possible in the disease course to slow or halt progression at an earliest stage as possible. When we think about the genotype-phenotype correlations, as you can see, there's many variants that can be responsible for TTR variant cardiac disease. And there's some with predominant neurologic features, some with predominant cardiac features, and some with a mixed phenotype. What are the high-yield ones to know about? V142I is the most important variant to be aware of. This is prevalent in 3.5% of Black Americans and has predominant cardiac involvement with rare neuropathy. Now, that does not mean that 3.5% of Black Americans will ultimately manifest symptomatic cardiac amyloidosis. However, a higher index of suspicion in this population is paramount to reduce the risk of underdiagnosis and underdiagnosis bias. The other forms to be aware of in America include T60A, L111M. Again, these can occur in American populations, but note that some have more predominant cardiac involvement, some more neuropathy. But remember, V122I, highest yield. Think about the cardiomyopathy, less likely neuropathy. So when it comes to amyloidosis, we need to have a high index of suspicion. The heart failure symptoms are but the tip of the iceberg, and we must be aware of what lies beneath. Patients may have more nonspecific symptoms like fatigue or other cardiac conditions like atrial fibrillation, AV block, pacemaker. As we'll discuss in an upcoming slide, a significant proportion of patients with aortic stenosis or HFpEF have concomitant or underlying cardiac amyloidosis. Think about that increased LV wall thickness, especially if the QRS voltage doesn't fit with what you'd expect from increased hypertrophy of the muscle. Is it hypertrophy or is it infiltration? The neurologic symptoms include a sensory neuropathy. There can also be autonomic dysfunction, predominantly with orthostasis. Say a patient has a little bit of hypertension and you put them on a little bit of a vasodilating antihypertensive and all of a sudden they feel like they're going to faint every time they stand up. That can be a sign of autonomic dysfunction, orthostatic hypertension. The orthopedic manifestations include commonly carpal tunnel syndrome, spinal stenosis, which may predate the cardiac manifestations by a number of years, again forming a clue to diagnosis. So now that we've talked about the first hurdle, which is having a high index of suspicion, let's move on to diagnosing ATTR cardiac amyloidosis. It's not the kind of condition that's going to jump out at you on routine blood work. It's the kind of condition where you must have a high index of suspicion based on clinical clues, so you order the right tests and interpret them in the right way. So talking about that thick heart, let's remember that a thick heart isn't always left ventricular hypertrophy, right? Hypertrophy implies that you know that that thickness is coming from too much muscle. But it doesn't have to be too much muscle. It might be infiltration into the muscle. So whenever you're presented with an echocardiogram and maybe the report says LVH, take a step back and ask yourself, is this too much muscle? Explained by loading conditions like hypertension, aortic stenosis, athlete's heart. Unexplained, could it be hypertrophic cardiomyopathy? Or is it infiltration into the muscle? And of all the conditions that can cause infiltration into the muscle, resulting in increased left ventricular wall thickness, amyloid cardiomyopathy will be the most common. And you have to keep an open mind because there may be more than one diagnosis, or some of the clues you use for diagnosis might not be as reliable as you think. So we all think, well, if you have infiltration into the muscle, you're going to have low volts on your electrocardiogram. Not necessarily so, as this observational study of patients with cardiac amyloidosis indicates less than 40% of patients have low voltage. However, about 80% will have discordant voltage. So just think about lower voltage than you might expect. What about patients who present for admission for decompensated heart failure with a preserved ejection fraction? Do they have garden variety HFpEF or do they have something else? Well, in this case series, patients were sent through the standard diagnostic evaluation for cardiac amyloidosis, and 13% had underlying TTR. So it may be an underdiagnosed cause of HFpEF. Finally, what about your elderly patients with symptomatic severe aortic stenosis that you send for transcatheter aortic valve implantation? In this study, 16% had concomitant ATTR cardiac amyloidosis with a strong male predominance. So don't anchor solely on your low volts. Don't write off a HFpEF patient. Don't think just about aortic stenosis. Keep an open mind as you go through your diagnostic algorithms. So you've gotten through the first hurdle, you're thinking about the diagnosis. How do you make it? It's a relatively straightforward process. You will start with a monoclonal protein screen. If your monoclonal protein screen is abnormal, you do not pass go, you do not collect 200, you remember that tissue is the issue and you perform a biopsy. A positive monoclonal protein screen suggests there may be a plasma cell dyscrasia, MGUS, AL amyloidosis, multiple myeloma. Tissue is the issue. You will biopsy something. If the monoclonal protein screen is negative, then you can perform a technetium pyrophosphate scan, a form of bone scintigraphy, and if abnormal, you have made the diagnosis of TTR cardiac amyloidosis, and then we'll perform genetic testing. But there are some subtleties to this diagnostic algorithm that I'd like to highlight. First of all, you might have memorized, like I did in medical school, that when you're looking for monoclonal proteins, check an SPEP and an UPEP. No, SPEP and UPEP is not adequately sensitive. You must order immunofixation electrophoresis to fully exclude an abnormal monoclonal protein. You might have also memorized in medical school fat pad biopsy for amyloidosis. No. Fat pad is not sensitive, particularly for ATTR. You may start with a surrogate site, but you cannot end with a surrogate site. The gold standard is biopsy of the involved organ. Finally, the technetium scans have been a major advance in the field of cardiac amyloidosis, allowing for the non-invasive diagnosis of TTR cardiac amyloidosis. However, they are only diagnostic if the light chains are negative. 10 to 20% of patients with AL cardiac amyloidosis have a false positive technetium scan. So if you only order a technetium scan and you give the patient a diagnosis of TTR and you haven't excluded your light chains, that can be a potential death sentence because the untreated median survival of AL amyloidosis can be less than a year. You must never interpret your bone scintigraphy in the absence of a monoclonal protein screen. Now let's dive into that biopsy again. When do we actually biopsy someone? Well, there's really three situations it could happen. Again, your monoclonal protein screen is abnormal. Do not pass go, do not collect 200, biopsy something. What if your technetium scan isn't available for some reason? Well, then you may have to biopsy to get your TTR diagnosis. What if it's an equivocal scan, but you have a high clinical suspicion? Remember, a test is only as good as your pretest probability. And if your pretest probability based on clinical clues is high, don't stop. Maybe they have early TTR cardiac amyloidosis. Maybe they have a rare form that doesn't show up on a technetium scan. So trust your instincts and biopsy in that situation. Now, where should you biopsy? You can do a surrogate site, fat pad or bone marrow, or you can do the infected organ, typically kidney or heart. And these sensitivities are quite sobering, in fact. If we look at fat pad and bone marrow, we see that particularly for TTR, the sensitivity is less than 50%, and it's certainly not 100% even for AL. So if you're looking, especially for ATTR, these fat pads and bone marrows aren't sensitive, go for the heart. You may start with the surrogate site because you want to save your patients an invasive test, but you will not end there. So now we're going to get into the good stuff. We're going to do a practicum, approach to the patient with suspected ATTR cardiac amyloidosis. Lillian, a Black woman aged 76 years. 2 months ago, she was diagnosed with atrial fibrillation. She was initiated on metoprolol tartrate. She has hyperlipidemia, stage 3 chronic kidney disease, ejection fraction 45%. Interestingly, she had bilateral carpal tunnel syndrome with surgery 3 years ago. Current medications, apixaban, dapagliflozin, rosuvastatin, furosemide. She presents to the ER with worsening, generalized edema, fatigue, shortness of breath, atrial fibrillation, tachycardia, hyperkalemia, mildly elevated blood glucose. She's anxious but alert and oriented, blood pressure 106/60. She had been placed on the sacubitril valsartan and the metoprolol. Really, her doc was trying to manage her HEF-ref. She had to stop them because of lightheadedness. On exam, she has jugular venous distension, bibasilar crackles, a systolic ejection murmur, and generalized pitting edema. So now I'm going to phone a friend, my fellow expert, Dr. Selvaraj. Dr. Selvaraj, what do you consider to be the red flag features in her medical history?
Well, thank you so much, Dr. Kittleson. So I think it's really important to take the entire case and put these clues together because none of these features in and of themselves are diagnostic of, ATTR cardiac amyloidosis. But let's figure out what might hint at it. So the first thing is looking at the demographic. And so you had mentioned that V142I is particularly prevalent in Black Americans, and especially as we get older. So that's the first context clue here. The second is atrial fibrillation. Now, of course, you can get atrial fibrillation for a lot of reasons. It's not always cardiac amyloid. I would say that it's more likely to be something else, but that is the second clue. The third is an ejection fraction that's mildly reduced. And so I'll be showing you some data later where we look at this and the relationship of having a reduced ejection fraction by the time you're hospitalized in cardiac amyloidosis. You had also highlighted the bilateral carpal tunnel syndrome and surgery that this patient underwent several years ago, and we know that that is sometimes a sign that precedes the heart failure diagnosis by several years. And I think the other important clue that you had pointed out in this case is intolerance to guideline-directed medical therapy. So in particular, sacubitril/valsartan, which has a potent vasodilating effect, as well as beta blockade, which were stopped in this situation due to intolerance. So a few clues here that we should be digging a little deeper.
Amazing. I couldn't have said it better myself, and I will not womansplain you by explaining it again. You did an amazing job. Thank you. Okay, so now let's get some more data about Lillian, a Black woman aged 76 years. She has an ECG, shows atrial fibrillation, echocardiogram. Her LV septum and posterior wall are increased thickness, 1.3 centimeters. We're not going to call it LVH. We're going to say increased LV wall thickness because we're not anchoring on it being muscle. Her EF now is 50%, still not great, right? Moderate aortic stenosis, mean gradient 25, estimated right ventricular systolic pressure 45. Because someone had the brilliant idea to think deeper about her presentation, she underwent dedicated amyloid-specific testing. Monoclonal protein screen was negative. No monoclonal band on serum or urine IFE, not just SPEP, IFE. Serum kappa lambda ratio was normal. She had a technetium scan that was positive, grade 2 or 3 uptake is positive, and her laboratory testing showed an elevated NT-proBNP, elevated troponin. You might say, well, I kind of expect her NT-proBNP to be high. She's in decompensated heart failure. Troponin, not typical of garden variety HFpEF, but can occur when you have infiltration. So let me send it back to you, Dr. Selvaraj. What do you think about these test results?
So I think very helpful, and obviously, they got pretty far in this case in trying to figure out what's going on so far. So we talked about the mid-range ejection fraction, which is more common, especially in the hospitalized setting in cardiac amyloidosis, the moderate aortic stenosis. So we know from the slides that you had shown earlier that there's an increased prevalence of ATTR-CA, particularly in low flow, low gradient aortic stenosis. The team did their due diligence, so they made sure to screen for monoclonal proteins, and those are negative. And then they went forward to undergo a PYP scan showing grade 2 uptake, which is considered diagnostic of cardiac amyloidosis. And I think you're right, NT-proBNP is helpful in a prognostic sense. It is not diagnostic. We have seen in ATTR-CA significantly elevated NT-proBNPs, even in the context of not having atrial fibrillation or not being hospitalized. But certainly, we've made a lot of progress so far in figuring out what's going on with Lillian.
Excellent. So we're very happy that the clinicians caring for this patient ordered the right test and interpreted them the right way. And so when we think about our stepwise approach to the assessment of individuals with shortness of breath and or edema, start by asking yourself, do they meet the definition of heart failure? Do they have signs and symptoms of congestion, structural, functional, cardiac abnormalities? But could it be another organ's fault? Is it a non-cardiac mimic? Maybe it's congestion primarily from kidney disease, liver disease, chronic venous insufficiency, and the heart is an innocent bystander, and we shouldn't be directing our efforts there. But if you do this mental exercise and you believe it is the heart's fault, then ask yourself, is there a cardiac mimic? Is there an infiltrative cardiomyopathy? And only after you've convinced yourself there is no mimic can you assign the patient a diagnosis of garden variety HFpEF. Now, I'm never one to advocate for more testing, but I will always advocate for more thinking. So this mental exercise is crucial for all the patients you care for, and don't forget about cardiac amyloidosis. And when you think about the diagnosis, remember that there might be cardiac manifestations, but there are also musculoskeletal, neuropathy, sensory, as well as autonomic dysfunction, so that seemingly disparate findings can contribute to a satisfying, unifying diagnosis. So much of medicine is pattern recognition. Form these mental patterns of paying attention to things like the carpal tunnel, spinal stenosis, neuropathy, and orthostasis. Well, I'm delighted now to hand it off to my colleague, Dr. Selfaraj.
Thank you so much, Dr. Kittleson. Truly a masterclass presentation from a master clinician. It is absolutely my privilege to take you through some of the treatment considerations in ATTR, which is a field that has recently, for lack of a better phrase, really exploded in the past couple years. So let's first talk about guideline-directed medical therapy in cardiac amyloidosis. So using the same treatments that we use in heart failure, can we do it? This audience is likely well familiar with our typical treatments that we employ: ARNIs, RAS inhibitors, beta blockers, MRAs, SGLT2 inhibitors, all class 1 indications. And as we think about different patient populations, there are more niche indications potentially. And the treatment of HFpEF has obviously changed as well in the last couple of years too. So some of these guideline-directed medical therapies need to be considered differently in the context of cardiac amyloidosis about their appropriateness. So whenever we think about cardiac amyloidosis, we're thinking about restrictive physiology and in particular a fixed stroke volume. So what about heart rate? So we may need to increase our reliance on heart rate to maintain cardiac output in cardiac amyloidosis, and therefore beta blockers may not be as well tolerated. Similarly, in cardiac amyloidosis, given a fixed stroke volume, vasodilators are not often as well tolerated given our inability to generate an increased stroke volume in response to vasodilators. So we're basically not getting any benefit and just getting some side effects, including hypotension there. It is important to note that in the pivotal trials, in the heart failure trials themselves, that patients with cardiac amyloidosis were typically excluded. At least patients with known cardiac amyloidosis were typically excluded. And so how do we know about whether we can use guideline-directed medical therapies? We have to rely on observational data as well as anecdotal experience. So this is a relatively large study looking at patients with cardiac amyloidosis and ATTR who are on beta blockers, ACE inhibitors, and ARBs and MRAs. And you can see that, first focusing on beta blockers, that there did appear to be a significant association between beta blockers and improved survival in patients with a reduced ejection fraction, and that's important to note. Let's move on to the middle panel here, where we look at ACE inhibitors and ARBs, and there was no significant benefit noted with these therapies, again, in an observational study. And finally, going to the right with MRAs, there appeared to be a survival benefit associated with MRAs. It's also important to look at the discontinuation rate for each of these medications. Beta blockers were discontinued in 285 patients out of more than 1,300. This was even higher for ACE inhibitors and ARBs, with nearly 450 discontinued in over 1,300 patients, while MRAs were typically the most well-tolerated as well. What about the newest kid on the block, SGLT2 inhibitors? And so this is with a similar cohort of patients looking at SGLT2 inhibition in an observational fashion. And you can see that SGLT2 inhibition was associated with a lesser decline in eGFR compared to no SGLT2 inhibition, a lesser increase in NT-proBNP, and a smaller decline in systolic blood pressure, at least indicating that they appear to be well tolerated. So how do we think about the pillars of care that we typically employ in heart failure in patients with cardiac amyloidosis? In general, we need to be careful with beta blockers, and there may be a greater role if there is a reduced ejection fraction. And in that setting, we would be careful and largely rely on non-vasodilating beta blockers such as metoprolol. There's probably little role for RAS inhibition, as mentioned. They tend to be not well tolerated. MRAs and SGLT2 inhibitors appear to be relatively well tolerated and can help manage volume very well. And this is just a reminder, especially in this case, in thinking about Lillian, that if you have atrial fibrillation and cardiac amyloidosis, oral anticoagulation is indicated regardless of the CHADS-2 VAS score. We spent the last few slides thinking about general therapies in patients with heart failure. Now let's focus on specific therapies for ATTR cardiomyopathy. Dr. Kittleson went through this figure earlier in how the TTR protein itself becomes destabilized and deposits into tissues in the body, including the heart. And so now we have several different ways that we can focus on reducing the risk of cardiac amyloidosis. We can start with targeting TTR production and inhibiting TTR synthesis. This has historically been accomplished with liver transplantation. But given a number of new therapies, such as the small interfering RNAs, the antisense oligonucleotides, that we've got away from liver transplantation as a primary option and focused on these novel therapeutics. Excitingly, there's also been data on gene editing in this space, which is very interesting and encouraging in its nascent phase. We can also focus on stabilizing the TTR molecule itself. Again, this has historically been accomplished with diflunisal, which is a non-selective agent. And now we have more selective agents available, including tafamidis and very recently acoramidis. Finally, we can try to remove the fibers once they are already deposited in the heart. This has been accomplished with doxycycline and TUDCA, and more recently, there are data to support monoclonal antibodies in this early research phase. As mentioned, there has been an explosion of interest in this space, particularly over the last 5 to 6 years. I like this figure a lot because it can show you all the cardiomyopathy trials and the polyneuropathy trials on the top and bottom, respectively. You can also see the phase 3 trials, which are indicated by the interrupted dashed lines around each of the trial names here. And so let's focus on the top with ATTR-ACT. This was accomplished and published in 2018. And you can see since then there have been several phase 3 trials, including Endeavor, Apollo-B, Attribute-CM, HELIOS-B, and then CardioTransform is estimated to complete and publish ideally by 2026 at least. So you can see that there's really a number of therapies that have come out just even in the last 5 to 6 years with several under investigation, and that will likely come to phase 3 trials as well in the near future. So let's talk about the ATTR-ACT trial, which really put targeted therapies on the map for ATTR-CA. This is a study of 441 patients, which was stratified by wild type and variant TTR status in patients with New York Heart Association class 1 through 3 symptoms. Patients were randomized to 2 doses of tafamidis, 80 milligrams and 20 milligrams versus a placebo. So there were 3 arms total, and they were followed for 30 months. Importantly, there was a significant reduction in all-cause mortality with tafamidis, 29.5% in the pooled tafamidis arm versus 42.9% in the placebo arm, which yields a relatively small number needed to treat of 7.5 to prevent 1 death over 30 months. Importantly, it was a well-tolerated treatment. Adverse events were similar between groups. There was also a significant reduction in cardiovascular-related hospitalizations as well. So tafamidis, therefore, as mentioned, is a stabilizer, and that is indicated for the treatment of ATTR-V and ATTR wild type in adults to reduce mortality, cardiovascular mortality, and cardiovascular-related hospitalizations. It's been approved for several years in the United States since 2019 and then 2020 in the EU. It's important to note that early treatment matters, but it doesn't reverse the disease process, and that patients will unfortunately continue to decline over time in some metrics, but at a less significant rate. So how do we know that? So if you look at the graph on the left, this is the ATTR-ACT subgroup analyses. Survival analysis is shown on the left. Cardiovascular hospitalization is shown on the right. And if we focus on the right, you can see that New York Heart Association class 1 or 2 patients derived a significant benefit. And there is a signal that this may not be as true in patients with class 3. And I think this remains very controversial. And I think most people tend to think that because of the mortality benefit, there is a competing risk and there is an increase in the number of cardiovascular hospitalizations. And so it was not necessarily that patients with class 3 weren't deriving benefit, but more or less related to that survival benefit that they actually accrued. There's also data from the long-term extension study of ATTR-ACT, and you can see continuous tafamidis on the top, placebo to tafamidis after 30 months in the trial, and then an extrapolated placebo as well. And the group that did the best was continuous tafamidis. You can see that the curves are starting to level off with placebo to tafamidis towards the end there, but in general, I think this underscores the point that early treatment does matter with ATTR-CA. So now let's jump into acoramidis in the ATTRibute trial. This is a study of another potent TTR stabilizer. This was an even larger study than ATTRACT, with roughly 630 patients in this study who received acoramidis or placebo. As in ATTRACT, most patients were wild type with regards to their ATTR. And the primary analysis used a win ratio. And so the win ratio is different than a hazard ratio, and it's important to understand the distinction. Win ratios have been increasingly incorporated into the cardiovascular statistical analysis plans, in part because we think that they may have greater power to detect differences between groups. The win ratio allows you to analyze composite endpoints in a hierarchical manner, so we can weight mortality more than heart failure hospitalization, more than 6-minute walk distance, for example. And we can also look at recurrent events using a win ratio. So again, not to be interpreted in the same manner, but another technique to prove differences between groups. In this study, because tafamidis had been approved, the study investigators needed to understand how best to incorporate patients who were on tafamidis, who were to begin tafamidis in this study. And so in ATTRibute, tafamidis treatment was not allowed during the first 12 months of the study, but it was allowed thereafter. And so looking at patients who were started on tafamidis, roughly 18% of all patients were started at a median time of 17 months from time to enrollment, and that they were treated for about 11 months. You can see on the right side of the screen here that there is a significant win, quote unquote, for acoramidis, with an improvement in death from any cause, cardiovascular rate of hospitalization, NT-proBNP, and a 6-minute walk distance with a win ratio of 1.8. And this was similar when looking at different combinations of those hierarchical components. So now let's look specifically at mortality and cardiovascular hospitalization. You can see that all-cause mortality favored acoramidis at 19.3% versus 25.7%. It also favored tafamidis for recurrent cardiovascular hospitalization, with 26.7% of patients in the acoramidis arm versus 43% of placebo. And that if you combine the two, there was an absolute risk reduction of roughly 15% with a 42% relative risk reduction. It's important data. And now let's look at some of the other secondary endpoints in the study, including NT-proBNP, 6-minute walk distance, quality of life as assessed by the Kansas City Cardiomyopathy Questionnaire, and then serum transthyretin levels. You can see that acoramidis was associated with a significant reduction in NT-proBNP. It went up to a smaller extent than placebo. There was a lesser decline in the 6-minute walk distance with acoramidis versus placebo. There is a significant improvement compared to placebo in the Kansas City Cardiomyopathy Questionnaire. Both arms tended to decline, but again, acoramidis declined at a less significant rate than the placebo arm did, and that there was a significant increase in serum TTR, which is proof of concept for how this molecule is working. And so if you look at the effect sizes for everything that we talked about, roughly 50% reduction in NT-proBNP, an increase in the 6-minute walk distance of 40 meters, which is near clinical significance, an improvement in 10 points in the Kansas City Cardiomyopathy Questionnaire, which is considered at least a moderate to large improvement in quality of life, and then a significant increase in serum TTR levels as well. Similar to tafamidis, adverse events were similar between both of those groups. So in conclusion, we saw that acoramidis resulted in significantly improved outcomes with regards to mortality, morbidity, and function versus a placebo. These data are hot off the press, and so really great timing for us to be able to include in this presentation. This is from the open label extension study. So patients, after they completed the study and were on the placebo arm, crossed over to acoramidis in an open label fashion. And you can see that the improvement in acoramidis versus placebo reached statistical significance for all-cause mortality with a p-value of 0.006 and a hazard ratio of 0.64. There's also a significant improvement in the open label extension study up to month 42 as well, with cardiovascular hospitalization with a hazard ratio of 0.53 and a p-value of less than 0.001. And these curves actually appear to diverge relatively early for cardiovascular hospitalization too, which is very notable. So what about vutrisiran, which is studied in the HELIOS-B trial? This is a study, again, of a similar number of patients, 655 in this case. They were randomized to subcutaneous injections of vutrisiran versus a placebo for 36 months in this study. The primary endpoint was a composite of death from any cause and recurrent cardiovascular events. And secondary endpoints included change in 6-minute walk distance, as well as the Kansas City Cardiomyopathy Questionnaire quality of life results. And so likewise, similar to the ATTRibute study, in HELIOS, there were patients who were also on tafamidis given its earlier approval. And so they dealt with this in two ways. Patients were allowed to enter the study on tafamidis. And if they were not on tafamidis to begin with, they were able to start the medication after 12 months. So similar concept to the ATTRibute study. You can see that 40% of patients were taking tafamidis at baseline, which is a relatively high number, and that 21 and 22% of patients began tafamidis during the trial. They were studied in two different populations. So there's an overall population, so patients who are on tafamidis at baseline and patients who are not on tafamidis at baseline. And in the monotherapy population, it was patients who are not taking tafamidis at baseline. If you dropped in with tafamidis treatment during the study, the time to initial drop-in was 17 months, approximately, in both of these arms. So let's look at the overall population on the left, and then we'll look at the monotherapy population on the right. Again, in the monotherapy population, none of these patients were on tafamidis at baseline. You can see the time to first event shown on the top left in the overall population, significant reduction with a hazard ratio of 0.72 and a p-value of 0.006, and death from any cause, so all-cause mortality, with a hazard ratio of 0.65 and a p-value of 0.01. Now let's look at the monotherapy population, so patients who are not on tafamidis at baseline. And I would argue, in general, similar results, a hazard ratio of 0.64 and a p-value still statistically significant, as well as all-cause mortality. And so with vutrisiran, which reduces TTR production, reducing the levels of circulating TTR protein with vutrisiran led to a reduction in the risk of death from any cause as well as cardiovascular events. Again, some newer data that we're delighted to show here, which were simultaneously published with the American Heart Association. These are data from vutrisiran looking at outpatient worsening heart failure with essentially an intensification of diuretics in the outpatient setting. And so you can see here, looking at the bottom left of the screen, that the initiation or the increase in oral diuretics is associated with a significant association with all-cause mortality as well as recurrent cardiovascular events in the overall population as well as in the monotherapy population or the baseline tafamidis subgroup. So prognostically important whenever we are increasing or starting diuretics. And vutrisiran significantly reduced outpatient worsening with a hazard ratio of 0.73 and a p-value of 0.009. And if we include outpatient worsening as part of the composite endpoint, you can see similar results with a hazard ratio of 0.69 and a p-value of less than 0.001. So very exciting data here too. Now let's compare all three of the trial populations. You can see that in general, the average age is around 75 to 78. There's a predominance of men in this study with only about 9% women. And in general, there is a predominance of self-identified white individuals as opposed to Black. Most patients are wild type as opposed to variant. And that going across the trial, so going left to right, ATTRACT to ATTRibute to HELIOS-B, you can see that there is an increasing percentage of New York Heart Association Class 1 and a decreasing percentage of New York Heart Association Class 3. This is accompanied by a decrease in NT-proBNP levels, as well as an increase in early NAC stages and a decrease in later NAC stages. So all to say that as we go from ATTRACT to ATTRibute to HELIOS-B, the patients appear to be less sick. And maybe that relates to earlier identification of our patients over time. And ATTRibute as well as HELIOS-B, of course, as mentioned, did allow tafamidis use at some point during the study. I really like this figure, which is published by Dr. Gerard and Dr. Sperry in Heart Failure Reviews, which shows all-cause mortality by each of the trials. ATTR-ACT is at the bottom here, then ATTRibute, then HELIOS-B, and then there's a line that depicts the age-expected mortality. And you can see that even just looking at the placebo arm in each of these trials is getting, quote unquote, healthier over time. And therefore, at some point, it's going to become very difficult to show a benefit in all-cause mortality. But very exciting that we're starting to approach, with the treatment arm in HELIOS-B, the age-expected mortality rate as well. So we saw some really exciting data from vutrisiran, and let's contextualize that with other TTR silencers. So are there general benefits observed with other therapies, or is this specific to the medication? So we can look at a post-hoc analysis of Apollo, which looked at variant ATTR. You can see that in the ACO substudy, there was a decrease in LV strain and thickness and a decrease in NT-proBNP. Inotersen likewise showed a decrease in mass and thickness, a decrease in BNP, and increase in 6-minute walk distance. With Neurotransform, there is improved left ventricular ejection fraction and stroke volume. Endeavor sort of breaks the mold here, and Endeavor was actually stopped early due to an increase in deaths in the treatment arm compared to the placebo arm. So important to note that. With Apollo B, less decline in 6-minute walk and a stable or worse Kansas City Cardiomyopathy Questionnaire, so quality of life assessment. We already reviewed the data from HELIOS-B, and then CardioTransform is anticipated to complete in June of 2025. So there appears to be a near class effect aside from the data from revusiran here that support the incorporation of TTR silencers. So let's put all the data we have together. This is from the ACC Expert Consensus Guidance document. Once we have a patient with confirmed ATTR amyloidosis, we'll treat their heart failure, and given what we talked about earlier, we'll avoid vasodilators, we'll consider mineralocorticoid receptor antagonists and SGLT2 inhibitors, loop diuretics as needed for volume control, and in some patients, we'll think about heart transplant and palliative care when appropriate. We need to focus on disease-modifying agents as well. If a patient has ATTR cardiac amyloidosis that is wild type, our approved options are tafamidis and acoramidis. And in the coming months, we may have another option, including vutrisiran. If they have variant-related ATTR and cardiomyopathy, our options again are tafamidis and acoramidis, and we will have to see about vutrisiran in the coming future. If they have a mixed cardiomyopathy and neuropathy, we have some different options available, including tafamidis, patisiran, vutrisiran, and eplontersen. And finally, for neuropathy, we have patisiran, vutrisiran, and eplontersen. Finally, focusing on the arrhythmias, there is a paucity of randomized data in this space. So in general, with atrial fibrillation, there are considerations for rate and rhythm control, which are outside of the scope of this presentation, but in general relies upon expert opinion and expertise, and some standard indications as well for pacemakers and ICD in patients with ATTR-CM. So this is a glimpse into the future about what's possible. On the left is CRISPR-Cas9, so that's in vivo gene editing. There are some early data that's been presented, which showed significant knockdown of the TTR protein with CRISPR-Cas9 gene editing, and an update was recently presented at the AHA as well. The phase 3 trial of Magnitude is anticipated to complete in April of 2028. And then there's antibodies, which we hope will actually reverse the disease process and deplete amyloid that's already deposited in the tissues itself, with some early encouraging data that's been recently published last year. So let's jump back to our practicum and talk about individualizing the treatment for ATTR cardiomyopathy for our patient Lillian. She underwent her workup, which included a clinical diagnosis of ATTR cardiomyopathy on the basis of a positive PYP scan, as well as negative light chain testing, which is very important, of course. And the patient also went on to undergo a TE cardioversion to treat her rapid atrial fibrillation. So now, as our cardiologist, we're left with the question of what's the best approach to targeted treatment for our patient. Well, as of this recording, there are currently 2 available options we have as discussed. Those include tafamidis, as well as acoramidis. In this case, the patient was started on tafamidis, although acoramidis would be a very reasonable option as well. So just jumping back a little bit and thinking about her atrial fibrillation, this comes up commonly about whether you need a TEE prior to cardioversion, with the idea that some data had suggested high thrombus rates in the left atrial appendage in patients with cardiac amyloid. This paper came out earlier this year, and I think at least gives us some more food for thought. So these were patients who were scheduled for cardioversion procedures. 69% actually did not undergo a pre-cardioversion TEE. And in those patients, there was 99% procedure success and importantly, 0% for thromboembolic complications. In the patients that did undergo a TEE, a significant number did reveal a left atrial appendage thrombus, so 12 in this study out of the 60 initial patients, and 48 did not reveal a left atrial appendage thrombus. So, of course, there's a lot of clinical judgment that needs to be considered in this case, but it does appear that in some patients, or potentially even in most patients, they may not need a pre-cardioversion TEE. That being said, most clinicians will still perform a TEE, and these data are considered, at the very least, provocative. So back to the case. So the patient was transferred to the intensive care unit. She achieved hemodynamic stability. She had improved kidney function. Her hyperkalemia resolved. She was discharged after 8 days. Her medications were adjusted. So Lasix 40 milligrams BID kept the same. Apixaban 2.5 milligrams. Dapagliflozin 10 milligrams, all the same. You'll notice that the rosuvastatin was dose reduced and tafamidis was initiated. There is a potential interaction between rosuvastatin and tafamidis, and therefore the rosuvastatin was decreased, since there are case reports of elevated CK and rhabdomyolysis with tafamidis and rosuvastatin and torvastatin at higher doses. So an important interaction to keep in mind. The patient was also started on amiodarone as well as spironolactone, which we mentioned was generally a well-tolerated medication in cardiac amyloidosis. She was discharged from the hospital and she followed up in clinic, and after her clinic evaluation and genetic sequencing was performed, and the V142I variant was indeed identified as had been suspected since earlier in the case. It's important to note that we have some really great trials that have come out, especially in the last 5 to 6 years, but compared to a lot of other areas in heart failure, we don't have as much higher levels of evidence to support some of the clinical decision making that needs to be done. So in general, shared decision making is increasingly important in ATTR, particularly in areas where we do not have as much data to help guide our care for these patients. So I'm also going to get Michelle back in here and get her advice on what types of surveillance do not need to be repeated in somebody with established ATTR-CA. And we'll also talk about which tests would you order to assess progression of ATTR-CA in a patient who's diagnosed. We have several options, which are detailed at the bottom of the slide here. So maybe, Michelle, I can ask you for some wisdom. Of these options, what would you not repeat in somebody who has an established diagnosis of ATTR-CA?
I love that question because, again, so much comes down to judgment and experience, and it's very important in medicine to never do a test that won't change your management. So if you have already established your diagnosis, you certainly don't need to repeat any of the diagnostic tests. So you would not repeat the endomyocardial biopsy if you happen to use that to make your diagnosis. You would not repeat your technetium pyrophosphate scan. We didn't talk a lot about MRI, but that's an interesting point in that an MRI is neither necessary nor sufficient for the diagnosis of cardiac amyloidosis, though, or I should say TTR cardiac amyloidosis. There will be characteristic findings of diffuse late gadolinium enhancement in patients who have cardiac amyloidosis, but it can't distinguish the types. So it wouldn't be necessary to confirm with a cardiac magnetic resonance imaging. So I would say those diagnostic imaging or invasive tests are certainly not required in someone who has established diagnosis.
Excellent, Dr. Kittleson. So I totally agree. I think the endomyocardial biopsy in this situation would be superfluous and would not help at all. And PYP at this point is largely a diagnostic modality. In the research world, maybe people have been looking at serial PYP, but certainly in a clinical setting and in a practical setting, that at this time does not need to appear to be repeated. And same thing with cardiac MRI. So we'll flip the question a little bit. So let's say, Dr. Kittleson, that you are seeing this patient now and you wanted to assess for risk stratification. What would you perform for this patient whenever you see them in clinic?
Now, this is a harder question. And this is a question that I suspect that if we were in person, we could actually physically arm wrestle to see who wins, because there is no right answer here. Again, it all depends. Now, is there prognostic value to things like NT-proBNP, troponin, echocardiogram, 6-minute walk test, KCCQ? Sure, there may be observational studies that indicate that changes in these markers or absolute threshold abnormalities in these markers may portend a worse prognosis. But again, I'm going to take a step back and say, how will this information change my management? And to me, to have the results of a test that exist in a non-actionable vacuum does the patient more harm than good. Now, I get that is a bit of an extreme position on the spectrum of judgment and experience, but a patient will sometimes ask me, hey, why aren't you doing that 6-minute walk test I heard about? Or why aren't you checking my NT-proBNP at every visit? And I say, what will I do with that information? So it is a bit of a moot point, and then we are worrying about something we cannot control, as opposed to focusing our energy on what we can, which is optimizing your medical therapy to augment and maximize your quality of life. So personally, and I know I'm a bit of an outlier here, I do not order these tests to assess progression because I cannot do anything with the information. Dr. Selvaraj, I'd love to hear your take.
Dr. Kittleson, as always, I love your pearls of wisdom, and I love how we need to think about how we manage these patients in the contemporary treatment era, now that we have two approved therapies, tafamidis and acoramidis. It remains unclear about how we sequence patients, about which drug first, or whether we think about combination therapy, especially with vutrisiran, which may be FDA approved in the coming year, and how we think about responders and non-responders. So if a patient is on one drug, their troponin is increasing, or their NT-proBNP is increasing, or their TTR level isn't increasing as much on one of these drugs, do we switch to another agent in hopes that they'll achieve a better therapeutic response? There's going to need to be a lot of research and data for us to help make these decisions. And until then, we're going to need to rely upon clinical decision-making as well as discussions with our patients to figure out what treatment is best for them and what their preferences are. We're also going to need to think about what insurance companies are willing to pay, considering some of these medications can be expensive.
And I'm going to take it a step farther. I know you're very optimistic. It's the optimism of relative youth, where you say in 3 to 6 or 9 months, we may need these tests. I would take it a step further and say, even if the landscape of available therapies changes, we still don't know how to deal with non-responders. And I imagine there will be some algorithm that we can use for guidance that will be disseminated, but it will be based on judgment, experience, but we do not currently have clinical trial evidence that even tells us what to do in that population.
And I hope we get that data someday. And you're right. I think it's going to take a lot for us to get that data and to figure this out. And until then, it's going to be a lot of excellent clinicians such as yourself thinking through these tough problems. So I get to close out the session with talking about the V142I transthyretin variant. The V122I nomenclature is the legacy nomenclature. But this variant, as Dr. Kittleson mentioned, is present in 3.4% of all self-identified Black Americans. In the United States, it is the most common inherited form of cardiac amyloidosis, and it is reportable as a secondary finding by the American College of Medical Genetics. Importantly, it demonstrates age-dependent anatomic penetrance, and all carriers over the age of 65 appear to have some element of cardiac amyloid deposition when looking at autopsy analysis. But the clinical penetrance is certainly different. And so we can look at heart failure hospitalization rates and death by age, and you can see that those risks with carriers go up significantly compared to non-carriers. We also looked at this. The previous slide was in ERIC, so in one community-based cohort. We also looked at this combining several different epidemiologic studies and could look at several different endpoints, including combined endpoint of heart failure hospitalization or death, all heart failure hospitalization, its subtype shown on the bottom side of the screen, as well as all-cause mortality. You can see a steep increase in the risk for essentially all of these outcomes over time. HFrEF in particular was significantly increased earlier on compared to HFpEF hospitalization, which is a much weaker signal that emerged in later life. So again, thinking about our case and thinking about Lillian, that HFrEF, so an ejection fraction of less than 50% by the time you're hospitalized, is actually relatively common, more so even than HFpEF when thinking about hospitalized patients. A statistically significant increased risk for each of these outcomes was achieved by the 60s and 70s, so 63 for heart failure, 65 for the composite outcome, and 72 for death. And when we think about the individual and overall impact of the variant on all-cause mortality, we can do so in a few ways. We can look at overall survival compared with non-carriers, and you can see that roughly there's 2 years of difference at each age of life between 50 to nearly 90 years of age. So carriers live 2 to 2.5 years less than non-carriers, since the expected longevity, of course, decreases as we age, and that difference in survival is relatively constant at 2 to 2.5 years. The relative loss of life actually significantly increases as we get older. And given an estimated number of Black individuals in the United States over the age of 50 of 13 million, we estimate that there are roughly 435,000 carriers over the age of 50 who are at risk for cardiac amyloidosis, and therefore with 2 to 2.5 years lost per carrier, this equates to a total number of carriers years lost in the contemporary cohort of living Black Americans of nearly 1 million years of life. So that's obviously a large population level impact there with the variant. Whenever we identify the variant, we of course want to think about cascade screening, because that's very important to identify other family members who may be potentially at risk, and for them to undergo evaluation as appropriate with a team who has expertise in cardiac amyloidosis. So we are very excited to understand how to best treat carriers who do not currently have cardiac amyloidosis. This is studied in the ACT Early study, which is a prospective multinational double-blind trial of acoramidis in carriers who do not currently have cardiac amyloidosis but are within 10 years of predicted age of disease onset. This is anticipated to be a 500-person trial of 5 years in duration who are randomized to acoramidis and placebo with an endpoint of cardiac amyloidosis diagnosis. So very important study that will hopefully gain some insight into in the next 5 to 6 to 7 years. So this has been a really terrific session, and just a few key takeaways for the audience. Thank you for your time and for listening. We know that some ATTR variants occur commonly in the United States. In particular, keep in mind the V142I variant, that there is variable multi-system involvement, which means that we all need a very high index of suspicion to avoid misdiagnosis. There are targeted treatments that are available with one that's currently FDA approved, and we anticipate more in the coming future, and that when initiated promptly can delay the progression of cardiac amyloidosis. The cardiology community is very, very well positioned to begin addressing this condition and this unmet need, and that transthyretin amyloidosis is an area of intense research interest with so many clinical trials that have been accomplished in the last 6 years, with several more in the pipeline.
On behalf of Dr. Selvaraj and myself, I thank you again for your attention.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from BridgeBio Pharma Incorporated. To access all materials for this activity, visit peerview.com/QTM860.